Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you all to part 101 of our pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. And the first question reads, SOL, 37-year-old patient, presents to the HIV clinic. This patient has a past medical history of hypertension, low back pain, and HIV infection. Now, due to his felony history, the medical team expects him to undergo random urine screen and labs. Today, his random urine drug screen reports positive results for tetrahydrocannabinol. So my question to you is, which of the medications listed below may cause false positive urine drug screens for marijuana? Is it itinaviir, marketed as Crixivan? Is it efavirenz, marketed as Sustiva? Is it rifampicin? Or is it zidovudin, azidothimidine, or retrovir? I'll give you 10 seconds to choose the correct answer. Efavirenz it is. I would like to start by saying that efavirenz, Sustiva, or Stockrin is an NNRTI that is known to interact with several urine drug assays used in the lab. Now, for reasons not specifically known, the reagents in the lab recognize or react to efavirenz or its metabolites, causing a false positive result. It is important to recognize this cross-reactivity when interpreting lab results, especially in patients who may be on parole or who is being hired for a new employment and undergoing random urine drug screening. So just watch out for that. Let's move to the next question, please. The next question reads, which of the statements listed below best describes the mechanism of action of flumadine in the treatment of flu? Is it true that it inhibits viral nucleotide synthesis within the viral nucleus? Or is it true that it inhibits the M2 ion channel on the endosome containing the virus, thus inhibiting the penetration of the virus into the host? Or is it true that it reversibly inhibits virus-specific thymidine kinase that stops viral DNA replication? Or is it true that it inhibits neuraminidase, thereby preventing the new viron from leaving the infected cell? I'll give you 10 seconds to choose the correct answer. It inhibits the M2 ion channel on the endosome containing the virus, thus inhibiting the penetration of the virus into the host. B is the correct answer. Now, as the virus enters into the cell, it is contained inside an endosome. The pH of the endosome must decrease in order for the viral life cycle to propagate. This acidification is carried out by the M2 ion channel. Now, blocking this channel will prevent the acidification of the endosome. I would just like to add that alternative C is the mechanism of action of antivirals such as acyclovir and valacyclovir, and D applies to the neuraminidase inhibitors such as oseltamivir, which is Tamiflu, and zanamivir, which is marketed as Relenza. Just as a by the way, let's move to the next question. And it reads, which of the medications listed below can decrease the absorption or bioavailability of atazanavir, marketed as Reataz, thereby putting the HIV seropositive patient at an increased risk of therapeutic failure and or development of drug resistance? Is it vitamin C, ascorbic acid? Is it ferrous sulfate? Is it the proton pump inhibitors and antacids? Or is it ciprofloxacin? I'll give you 10 seconds to choose the correct answer. PPIs and antacids is the correct answer. Now, the absorption or bioavailability of atazanavir is dependent upon acidic or low pH environment, and any medications that can raise the gastric pH or make it more alkaline can significantly negatively impact the overall absorption of atazanavir from the gut. Now, this results in lower drug concentrations, and that makes it subtherapeutic in the bloodstream, and that could affect the control of the infection negatively, and this increases the risks for drug resistance. Let's move to the next question, please. And it reads, Mrs. M.J.K., a 79-year-old female patient, has been admitted to your medical ward for the past 3 weeks with a past medical history of heart failure, hypertension, osteoporosis, and urinary incontinence. She is on day 7 of treatment for nosocomial pneumonia, and she has had 7 watery stools in the past 24 hours. She has no known drug or food allergies, and some of her pertinent lab results include a WBC of 18.7 times 10 power 3 cells per microliter, a serum creatinine of 2.4 milligrams per deciliter, and the baseline on admission was 0.7 milligrams per deciliter. So the kidneys are taking a hit. The PCR test sent for Clostridioides difficile come back positive. So my question to you is, which of the treatment options listed below would be the most appropriate for Mrs. M.J.K.'s treatment now? Would you opt to administer metronidazole, vancomycin, fecal transplant, or would you settle for fidaxomicin? I'll give you 10 seconds to choose the correct answer. I would choose to treat this particular case using vancomycin. Now, the SHARE IDSA guidelines for Clostridioides difficile infection state that vancomycin is the treatment of choice for severe infections, where severe means the WBC is equal to above 15 times 10 power 3, and the serum creatinine is equal to or above 1.5 times the premorbid level. Now, fidaxomicin is another option that can be used, but it is more expensive than vancomycin. Then fecal transplant is reserved as a salvage therapy for patients without other viable options. Just like to remind you that vancomycin should be dosed at 125 milligrams orally every 6 hours in this particular episode. Let's move to the next question, please. And it reads, Mrs. J.O.I., a 45-year-old female patient, develops an nosocomial pneumonia following 10 days of admission in your medical ICU. The intensivist decides to empirically treat her with vancomycin, cefepime, and levofloxacin. Her bronchoalveolar lavage is positive for Klebsiella pneumonia after 4 days of therapy. It is sensitive to both cefepime and levofloxacin. On day 5 of therapy, the intensivist discontinues all the antibiotics except levofloxacin. So my question to you is, for how long should Mrs. J.O.I.'s treatment with levofloxacin last? Should it be 21 days, 14 days, 8 days, or 3 days? I'll give you 10 seconds to choose the correct duration of therapy. I would choose to treat for 8 days. Now, 8 days of therapy was found to produce similar outcomes as 15 days of therapy for patients with ventilator-associated pneumonia. The subgroup analysis of this study suggests that 15 days may provide better outcomes for patients infected with non-fermenter gram-negative pathogens, such as those caused by Pseudomonas aeruginosa or Acinetobacter baumannii. Now, 3 days of therapy isn't acceptable for patients with CPIS scores that are equal to or less than 6 at baseline, and on the 3rd day of their therapy. So that makes alternative D wrong. And then 21 days and 2 weeks would be too long from an AMS point of view. Let's move to the next slide, please. And the question reads, Mr. G.B.Y., a 79-year-old male patient, is transferred from a general medical ward to the medical ICU following a failure to wean him off a mechanical ventilator after undergoing a hip replacement surgery. On day 1 of his MICU stay, he develops purulent sputum, fever, and hypoxia. The intensivist diagnoses VAP. Some of his pertinent labs are WBC of 22.3, a PCT of 60.4 nanograms per ml. The intensivist initiates GBY only nasally at a dose of 600 milligrams infused over an hour twice daily. 2 grams of cefepime infused over 1 hour thrice daily, and pantoprazole infused at a dose of 40 milligrams over half an hour once a day, with enoxaparin administered prophylactically at a dose of 40 milligrams subcutaneously once a day. On day 6 of hospitalization, Mr. G.B.Y.'s endotracheal aspirate is positive for an unspeciated Candida isolate. All his other cultures are negative. Some of the current labs include chemistry within normal limits. Procalcitonin is now 18.4 nanograms per ml, and the WBC is 16.1. Some of his vitals include a blood pressure of 142 systolic, 90 diastolic, a heart rate of 77, a body temperature of 99.3 degrees Fahrenheit. So my question to you is, which of the following would be the next best course of action in Mr. G.B.Y's case? Would you initiate amphotericin B at a dose of 3 mg per kilo IV infused over 4 hours? Or would you initiate micafungin at a dose of 100 mg IV infused over an hour once a day? Or would you continue linezolid and cefepime without changes? Or would you initiate fluconazole infused at a loading dose of 800 mg IV followed by 400 mg IV once daily infused over an hour? I'll give you 10 seconds to choose the correct answer. I would choose to continue with linezolid and cefepime. Now, it would be appropriate to continue with the same since Mr. G.B.Y's clinical status is improving on antibacterial agents, and the unspeciated Candida isolate is likely to be a contaminant due to the patients lacking any risk factors for invasive candidiasis. The other options aren't appropriate due to the absence of risk factors for invasive candida infection and lack of other positive cultures for fungal infection. Now remember, the candida found in the respiratory tract, the GIT or the urinary tract, is usually a contaminant indicative of colonization. Now, this pathogen is typically not clinically relevant unless there are multiple risk factors for disseminated candidemia, e.g. pre-existing immunocompromised state, for example, or the presence of a central venous catheter, or even if the patient underwent GI surgery. Now, in patients at high risk of candida infections, an echinocandin, such as micafungin, is preferred in clinically ill patients and in those who have recently been exposed to azole antifungals such as fluconazole. Now, the patients with less severe illness and no exposure to azole antifungals may be treated with high-dose fluconazole, that is 800 mg IV start followed by 400 mg IV or D, with renal dose adjustment done if necessary. So because this is a case of colonization, I would opt not to treat the colonizer. I would continue infusing linezolid and cefepime without using an antifungal. Now, there have been reports of Candida auris infections which has shown resistance to commonly used antifungals in many clinical settings, and the CDC recommends faster in treatment with echinocandins, that is anidulafungin, Caspar Fungi, and micafungin in such scenarios. Now, due to the absence of antifungal susceptibility breakpoints and the risk of development of resistance during treatment, those who don't appear to respond to treatment should be transitioned to liposomal amphotericin B. When using amphotericin B, patients should be monitored for hypokalemia and hypomagnesemia. Those would occur as adverse drug effects. Let's move to the next question, please. And it reads, Mr. T.D.J., a 47-year-old male patient, is being managed for a probable case of bacterial meningitis in your medical ward using IV ceftriaxone. Some of his allergies include amoxicillin, where he told you he had unspecified GI upset. This patient is now intubated and he can't clarify his allergy. So my question to you is, which of the following would be the next best course of action in this particular clinical scenario? Would you opt to change to piperacillin tazobactam administered over 4 hours, or would you continue administering ceftriaxone IV, or would you change ceftriaxone to aztreonam, or would you initiate penicillin desensitization protocol? I'll give you 10 seconds to choose the correct answer. I would settle for B. I would like to start by commenting that piperacillin tazobactam would fail you miserably. It would be tantamount to doing monotherapy, because we know that the tazobactam component does not cross the blood-brain barrier. So you would actually be treating with piperacillin alone, which may not be effective. Now, for patients aged between 2 and 50 years, the beta-lactam of choice is ceftriaxone. Now, in patients with reported histories of allergy to beta-lactams, a high-quality history must be undertaken to ensure that the patient does not receive suboptimal alternative antimicrobial therapy. Now, given this patient's history does not report any signs and symptoms concerning for anaphylaxis, there is more likely to be a case of intolerance rather than an allergy. So I would bite the bullet and infuse ceftriaxone. I would take chances. Now, given that the immunogenic element of the beta-lactams is the R1 side chain, and that amoxicillin and ceftriaxone don't share a common R1 side chain, the likelihood of cross-sensitivity is quite low, but not zero. Now, aztreonam is often thought of as a safe haven for penicillin allergic patients. Now, for patients who have had an allergy to ceftazidime, they are likely to have a similar allergy to aztreonam. This is because they share an identical R1 side chain. Now, ceftriaxone has a compensatory metabolism and elimination pathway with both the hepatic and biliary and renal systems involved. Just like to emphasize that penicillin skin testing is a tool that can be used to confirm or exclude beta-lactam allergies and potentially reduce patients' lifetime risk of developing multi-drug resistant pathogens or for receiving suboptimal antimicrobial care. So where feasible, I would advise you to use penicillin skin testing to confirm whether patients are allergic to beta-lactams or not. Let's move to the next question, please. And the next question reads, which of the mechanisms of action listed below corresponds to the echinocandin antifungal medications? Do they bind directly to new keratin and microtubules, or do they inhibit squalene epoxidase enzyme used to convert squalene to lanosterol, or do they inhibit fungal cell wall synthesis by inhibiting the formation of 1,3-beta-D-glucan, or do they bind directly to ergosterol and result in lysis of the fungus? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. I would like to start by saying that alternative D corresponds to the mechanism of action of amphotericin B and nystatin. Then alternative B is the mechanism of action corresponding to terbinafine. Then alternative A corresponds to the mechanism of action of griseofulvin. So the echinocandins actually inhibit fungal cell wall synthesis by inhibiting the formation of 1,3-beta-D-glucan. Let's move to the next question, please. And it reads, for which of the medications listed below should testing for G6PD be done prior to initiation of therapy? Is it for dapsone, pentamidine, primaquine, or atovaquone? I'll give you 10 seconds to choose the correct answer. So it should be done for dapsone and primaquine. Remember, primaquine and dapsone can cause hemolytic anemia in patients with the G6PD deficiency. Remember, the G6PD levels should be assessed prior to initiation of these agents to avoid this hemolysis from occurring. Now, pentamidine and atovaquone don't cause hemolytic anemia in patients with G6PD deficiency. Now, if patients are found to have G6PD deficiency, alternative agents should be used in therapy. Just like to remind you that G6PD deficiency causes increased susceptibility of erythrocytes to chemicals such as or to drugs or to hydrogen peroxide and even other reactive oxygen species that can lead to hemolytic anemia. It can also cause favism or chronic non-spherotic hemolysis, and even spontaneous abortions can occur in the pregnant ladies, and even neonatal hyperbilirubinemia can result. And this could even lead to neonatal kernicterus in extreme cases. Let's move to the next question. And it reads, Mrs. GMT, a 59-year-old female, underwent kidney transplant at your hospital 15 months ago. Currently, she takes sirolimus, mycophenolate, prednisone, NPH insulin, and regular insulin, and aspirin. Now, this patient developed candidemia caused by Candida glabrata, and culture and sensitivity results show it is susceptible to all azoles, polyenes, and echinocandins. So my question to you is, which of the treatment options listed below would be the most appropriate for Mrs. GMT? Would it be voriconazole, Caspar Fungi, amphotericin B deoxycholate, or liposomal amphotericin B? I'll give you 10 seconds to choose the correct answer. So Caspar Fungi would be the best choice here. I would like to start by saying that voriconazole, marketed as Vifen, and sirolimus, marketed as Rapamune, shouldn't be co-administered because voriconazole dramatically increases sirolimus serum concentrations, being a cytochrome P enzyme inhibitor. Now, while this is clinically relevant as a drug-drug interaction, there are some clinicians who consider reducing the doses of sirolimus by 50 to 90%. Now, failing to recognize this drug-drug interaction can lead to an 11-fold increase in sirolimus concentrations, likely due to the fact that voriconazole inhibits CYP3A4, and it also inhibits the P-glycoprotein pathway. both of which are used by sirolimus for metabolism and for elimination. Now, Caspar Fungi, which is marketed as Candida, is the agent of choice here due to superior safety profile, especially given the risk of nephrotoxicity with amphotericin B deoxycholate in a kidney transplant recipient. Now, Caspar Fungi can decrease tacrolimus levels through an unknown mechanism, but this potential interaction can be managed clinically. Let's move to the next question, please. And it reads, Mrs. GBT, a 47-year-old female, presents to your cardiology clinic with native valve endocarditis caused by Streptococcus bovis. This pathogen's MIC, according to your lab, is 0.25 micrograms per ml. She is allergic to vancomycin. The last time it was infused, she had flushing. She has a past medical history of dyslipidemia and depression, and currently she takes rosuvastatin at night and fluoxetine in the morning after breakfast. So my question to you is, which of the medications listed below would be the most appropriate choices or choice for Mrs. GBT's treatment? Would you opt for vancomycin for 4 weeks plus gentamicin for 2 weeks, or would you infuse vancomycin alone for 6 weeks, or would you opt for ceftriaxone for 4 weeks plus gentamicin for 2 weeks, or would you infuse penicillin G alone for 6 consecutive weeks? I'll give you 10 seconds to choose the correct answer. I would choose to infuse ceftriaxone for 4 weeks and gentamicin for 2 weeks. Now, penicillin or ceftriaxone should be combined with gentamicin for Streptococcus bovis strains with penicillin MICs that are above 0.12 mics per ml and equal to or less than 0.5 mics per ml. Now, I would just like to add that vancomycin is recommended as monotherapy for 4 weeks in such a patient, not for 6 weeks, so the duration there would be wrong. Then the addition of gentamicin to vancomycin isn't needed. You end up hammering the kidneys for no good reason. Let's move to the next question, please. And it reads, which of the antifungal agents listed below inhibits the synthesis of ergosterol and thereby inhibits cell membrane formation? Is it Caspar Fungi, valganciclovir, efavirenz, or fluconazole? I'll give you 10 seconds to choose the correct answer. Fluconazole is the correct answer. Now, fluconazole is an azole antifungal agent which is known to inhibit ergosterol synthesis, which would be incorporated into the fungal cell wall. Now, alternative B, valganciclovir or Valsite, is an antiviral agent which is converted to ganciclovir in the body, where it inhibits DNA polymerase to inhibit viral DNA synthesis. It has nothing to do with the fungi. Then efavirenz is an NRTI, which is used in the treatment of HIV infection, nothing to do with the fungi. I would just like to add that Caspar Fungi is an echinocandin antifungal agent that inhibits 1,3-beta-D-glucan synthesis, which is then incorporated into the fungal cell wall. So the best answer here is D. Just like to add that echosteral synthesis inhibitors such as fluconazole, itraconazole, ketoconazole, posaconazole, and voriconazole are enzyme inhibitors. So watch out for drug-drug interactions. I'd just like to remind you that fluconazole has a long half-life of about 30 hours, which allows for easy once daily dosing. And I would just like to refresh your memory that valganciclovir is a product of ganciclovir that allows easier use of an oral dosage form and better absorption. Now, valacyclovir, Valtrex, is the prodrug of acyclovir, which serves the same purpose of increasing bioavailability. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave a comment at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me. And I sincerely appreciate your partnership and your continued support and very kind collaboration. And I look forward to interacting with you in part 1 or 2 of our Pharmacotherapy MCQ series. Thank you very much for watching.